Health information is everywhere. It's confusing. We're sitting down with doctors to help make sense of it.
Take me to Kraus.
Take me to Kraus.
Take me to Kraus. They saved my life.
Welcome to the podcast studio at Kraus Hospital. Today we are talking SU athletics with the orthopedic surgeon whose job it is to keep the SU athletes on the field. Dr. Todd Battaglia, welcome to the podcast.
Thank you. Happy to be here.
So when we're at the Dome and we see that sign, exclusive healthcare partner of SU athletics, what does that actually mean?
I guess in its simplest terms, it means that Kraus Hospital has a very specific and designated relationship with the athletic department and in taking care of the athletes at SU. When it comes to me as the orthopedic surgeon for the athletes, I'm actually hired and contracted through Kraus to take care of them. But also Kraus is sort of their go-to guy in any sort of emergency situation or medical situation that needs to be taken care of outside the confines of campus. Kraus is the hospital that gets the athletes in immediately for imaging, for testing, for any sort of care they need.
Even mental health care?
Even mental health care.
Okay. So you're the guy who, when a football player goes down at the JMA Dome, you're the one who goes running out there.
I'm one of the guys.
Yes.
We have a good staff of athletic trainers and strength and conditioning coaches. Myself on the orthopedic side, doctors on the general medicine side. We're all part of a team that is running out there to take care of those injuries.
Also the basketball court, not to leave out the basketball players.
Thankfully, I have to run out much less on a basketball court than
I would imagine.
than a football field.
So what is it like when you literally are, all eyes are on the field, a player is down, and you've got tens of thousands of people sort of holding their breath? Like, are you in a zone so you don't even think about it anymore?
You try to be, for sure.
Yeah.
You really try to block that out and just take care of it like you would in the office or in the OR. You try to block out that everybody's looking at you.
In 20 years of practicing orthopedics, specifically surgery, what kind of changes have you seen?
Starting with the players, for better or worse, they're bigger and stronger and faster than they were 20 years ago. And so that has sort of resulted in a different level of injury and type of injury, and more frequent injuries, honestly. The training programs are more rigorous. There's a lot more effort put into some of the maybe aspects of things that one wouldn't think of, like nutrition and diet and some of those things. Equipment has changed tremendously, and really the overall rigor of the sport has changed. At a D1 level like Syracuse, it's a full-time, year-round job. I mean, they are doing football activities almost every day of the year to some degree.
I know this is not your area, but, we're in a new era of, NIL, and these players are, they're laying down and looking up at you, and in some cases they're, they are wealthy already, and they're 19 years old. Has that changed any of the dynamic at all?
It has in a couple ways. One is that most of these players now have outside influences they turn to. So when an injury might occur, they all have agents who may steer them in certain directions or want them to see certain doctors. So that's a little bit of interference. The big thing that affects me or bothers me is that, part of having a good doctor-patient or doctor-athlete relationship is trust. And so in the past, you would get to know these kids year after year. And now there's such roster changeover that you don't have those kind of relationships anymore. And so sometimes it's hard to build that, when a kid is only here for a year and then moves on to a different school and a whole new roster comes in.
Well, the fans feel very similarly. Right. It's like, wait a minute, we love this kid, and now this kid is playing somewhere else or off maybe doing, a professional gig if that's available. I know concussions aren't your specific area, but often you're one of the first people out there on the field. And I'll never forget, I interviewed Tim Green long before he was diagnosed with ALS.
Right.
He said to me, when I played and somebody would go down and you could see they took a hit to the head, the trainer would go like this: how many fingers? And if you said 2 or 1, they'd say, get back out there. Right, we laugh about it now.
I know.
He was laughing about it, but that was the way it was. Now, you have been here for that ride.
Yes.
You know, has it changed in that first and foremost we're thinking, how is this kid?
So, I mean, those pressures obviously are still there, often from the player themselves, himself or herself, that still wants to play and doesn't
Right.
want to sit out. But it has changed dramatically. I mean, even from my own college playing days when I was a lacrosse player, you didn't get a concussion, you got your bell rung, and you would sit out for a few minutes, and when you could see straight again, you went and played. Unfortunately, through tough lessons, we've learned that it doesn't work quite so simply, that there can be some longer lasting issues. And what particularly is at risk is the person who goes out and returns to play with residual symptoms. Their brain has not quite recovered and takes a second injury. That is where things go really south really fast. So concussions have become much, much more frequently diagnosed. Whether they're really occurring more or whether we're just picking up on them more and diagnosing them more readily is debatable. But really, these days, the benefit of the doubt goes to having a concussion. If a patient says, oh, I'm a little dizzy, or I got a slight headache or something like that, they're pretty much entered into a concussion protocol.
Right.
And we treat them as if they had a concussion.
Do you think that the helmets are better today at protecting their heads?
They are better, and some teams, including SU, use some extra protective layers during practice situations. What's very interesting is that many of the helmet makers and some researchers as well are working on helmets that can actually measure the pressure or the force that a player suffers during an impact injury or during practice. How many times was his head jarred? What was the velocity? What was the pressure he suffered? And it's really starting to test and monitor those things.
Wow. Let's talk a little bit about women's sports, because I'm sure that you were watching the Olympics with the rest of us in Italy just a few months ago, and Lindsey Vonn was standing there getting ready for her downhill run with a torn ACL.
Right.
And a lot of people just marveled at how, she could even walk, let alone ski, let alone go 80 miles an hour. Were you surprised that she actually was attempting this?
So, from an ability standpoint, it didn't surprise me that she was able to try. After you get over an ACL tear initially and the swelling and the bruising goes
Right.
down, it's typically not a terribly painful or limiting thing. You can walk around like a normal person with an ACL
Yeah.
tear. So, that didn't surprise me. What surprised me a little bit was that she was sort of counseled to give it a go. It was a very dangerous thing for her to try, and I understand
Right.
there's different opinions out there, and some doctors will say her tear had nothing to do with the crash and the shattered
Right.
leg. I'm not quite so sure I agree or believe that,
Yeah.
but I wasn't taking care of her.
Yeah.
But, I sort of understand the motivation. It's probably her last Olympics, and, come hell or high water, she's
is
gonna,
now.
yeah, right?
Yeah, right.
But yes, I mean, the standard advice for a skier who tore their ACL would not be to continue skiing on that knee.
Yeah. Why is it when you hear about high school girls, 13, 14 years old, or just field hockey, lacrosse, whatever sport, and all of a sudden, all these girls are tearing their ACLs? What is it about a girl's knees that are different?
Women do have some very specific intrinsic factors that make them more likely. Some of them include hormonal. Unfortunately, female hormones make ligaments more stretchy, and it probably comes down to the need for childbirthing. Your pelvis has to be able to stretch
Right.
pretty significantly to allow that baby to be expelled. The anatomy of their knee in terms of how the ACL sits and where it's contained between two different parts of the bone is often more narrow in females. So there's a theory that the ACL gets more easily pinched and sort of kinked if they twist the wrong way.
I see.
And then there's also some mechanical things. For whatever reason, women tend to have slightly different landing and cutting mechanics. They tend to do it with a bit more of a knock-kneed position, whereas guys tend to be a bit more bow-legged, and that also increases stresses on the ACL. And that's actually where a lot of the efforts at sort of ACL prevention programs are focused on, working on those mechanics and sort of retraining some of those landing mechanisms
Right.
and strengthening certain muscles around the hip and around the knee.
I want to talk about some of the newer type of surgeries that you're doing now, because things have really evolved in the last few years. cartilage and these different types of, delicate procedures that you can do. What are you excited about that you're doing now that you couldn't do just a few years ago?
Yeah, so I went through my training. I finished almost exactly 20 years ago. So I just, I'm not at the end of my career, but I've seen enough to sort of see where things go. And certainly within sports medicine, one of the more interesting and more rapidly developed things is, just as you said, treatment of cartilage injuries. So, there's sort of two different types of cartilage in the knee. One are these ring-shaped shock absorbers called the meniscus cartilage, and almost everybody's heard about
Yes.
a meniscus tear. Things have not been so dramatically improved in that area, other than we've recognized the importance of those cartilage structures, and rather than just sort of cut them out at a moment's notice like we used to, a lot more effort is made to actually repair those tears and to sew them back together. But the second type of cartilage is the joint cartilage, the stuff that coats the ends of the bone. So what I tell patients is, if you've ever broken apart a chicken wing and you see that glossy stuff on the ends of the bones, that's called joint cartilage or articular cartilage. And where most people know that from is when it wears down, that's what arthritis is. So for many, many years, we really had no way to treat a cartilage injury other than take some Motrin, do a cortisone shot, do some PT. It is what it is. If it ever gets bad enough, you get a joint replacement kind of thing. Now, if someone has really diffuse or bad cartilage wear, that's still pretty much the party line. But where we've really made leaps and bounds is younger patients who have had a more focal cartilage injury. They've had an injury and taken a chunk out of the end of the cartilage or a divot. And that often happens with other injuries like kneecap dislocations or ACL tears. We have ways from taking some of the patient's own cells and sort of multiplying them in a lab and then reimplanting them to grow new cartilage, to taking cadaver cartilage and transplanting plugs. So those things were just on the cusp of being started as I finished my training, and now they're relatively common procedures.
It seems like everybody I know has had either a hip replacement or a knee replacement or both knees. In the case of my husband, we're aging in a certain way where we want to be active. What about the use of robots? I know that that's not really what you do, but your partners at SOS, do it all day, every day. What do you think?
So we've got a department right now, if I'm counting correctly, of about 7 doctors who specialize pretty exclusively in joint replacements, hips and knees. I do shoulders, by the way, but robots haven't really hit that world quite as much. And all of them use robotic guidance to some degree. They do not do it for every single case. It's available. In fact, they do it right here at Krause, obviously. Krause has a number of robots that can be used for joint replacement. And it's sort of on a case-to-case basis, depending on the patient and their anatomy and where they think it might be helpful.
My parents, when they were my age, were not playing sports, and they weren't active like the people of my generation, and we are starting to ask for things to keep us
For sure.
mobile and keep us, on whether it's playing pickleball or golf or skiing or whatever. Have you noticed a huge shift in the patients who come to SOS saying, fix this?
100%. It's been a gradual thing, but patients are skewing older in terms of who wants to be sort of fixed, whereas, for instance, an 80-year-old for years may have been, I'm too old for surgery. I don't do that much anymore.
Right.
Well, now 80-year-old wants to play pickleball. They want to play golf. They still want to hike, kind of thing. So the age has skewered, and sort of our mental cutoffs for some of our procedures have shifted along with them. I mean, really, when I was training, if a 50 or 60-year-old tore their ACL, we would typically say, you don't need to fix this. Give up tennis, you can jog and you can swim, kind of thing. That doesn't fly with a lot of patients anymore. Obviously, most of our ACL surgeries are still young kids, but I've done ACLs on numerous folks in their 50s and 60s who still want to ski, who still want to do things that require a stable knee.
Are there things that you would say to people right now who are in their 30s, who really are active and see that as part of the rest of their lives? What can they do to ensure that they have the best chance of being able to do that without, maybe even needing to have surgery?
Sure. obviously there's nothing they can do to ensure that. But, if I had to make a rank ordered list, number one would go for every health issue applicable. Don't be overweight. Keep your body weight healthy. That's probably the number one stress on joints, number one thing that's going to lead to a lot of things we see. But beyond that, I would probably make an emphasis on cross training. Just like the reason more kids are getting injuries. Don't do the same sport every day, every week, every year. Mix it up so that different muscle groups are getting stressed in different ways. Different joints are getting stressed. This sort of sports specialization that 12 and 13 and 14-year-olds play soccer every season, every day, every weekend. It's a large part of why they're breaking down more than they used to. And the same goes for the adults.
Yeah. So what about weight training? Certainly at a certain age, they say that is the most important thing to do because you lose muscle mass,
Right.
Every decade. How important does that rank on your list?
It's big, not only for muscle mass but also for bone health as well. I mean, in terms of preventing osteoporosis and those and hip fractures and all those things that happen. Strength training is very important. And the other thing people tend to neglect is flexibility. There have been a lot of studies that show your flexibility is a great predictor of your injury likelihood when you get elderly.
Interesting. Back to the SU football team, they're doing yoga now.
Right.
Have you seen an improvement in flexibility, and has it made a difference?
That's a good question. I don't know if I've got enough data to be able to answer that, but they definitely do. They do yoga usually once or twice a week. Someone comes in and actually leads them. This isn't just 3 minutes of stretching at the end of practice. This is yoga.
Tell us a little bit about your background as an athlete and how it informs how you practice medicine.
Sure. So I grew up playing sports. I went to Marcellus locally here where I played basketball and soccer and lacrosse, and then I played lacrosse in college, also played rugby in college. And even after graduation, I played some level of sort of club or adult league lacrosse up until just a few years ago. So I played for a long time. I think probably the best thing it does for me in taking care of athletes is it gives you a little bit of understanding of, why their priorities might be a little different than the physicians or their parents. They don't always understand the long term. They just understand that playoffs start next week. And so I think it gives you a little bit of empathy and a little bit better ability to sort of talk to them.
And also you are living now and working in the place where you grew up.
Correct.
How does that affect the way you come into work every day?
Sure. It probably is most meaningful at the Dome, taking care of the athletes. I grew up here. We had seasons basketball tickets as a kid. If I made a list of all, probably the top 20 SU games, in fans' memory, I probably had 3/4 of them. And so now to be able to work with the team and be in that facility and be on the field, it is. It's moving.
Favorite player?
Of all time?
Yes.
Boy, that's a hard question. I probably grew up a little bit more of a basketball fan than a football fan, and I guess if you really go back to my childhood and who I spent the most time imitating, it was probably Pearl.
Pearl.
Yeah.
The Pearl. All right. Well, he's right up there for me too.
Yeah.
Maybe Sherman Douglas right behind
Not
him.
too far
Right.
away. Yeah.
And Mello. And Jerry. How about
Yeah,
Wait a
Jerry.
minute.
Yeah.
Jerry.
Jerry's back.
He's your guy. How do you feel about that?
It's awesome.
Yeah.
He's a great guy. Hopefully he'll do what he needs to, and we can get things back to the way we remember them in the 80s and 90s and, early 2000s too, when he was playing.
Wouldn't that be nice? Well, thank you, Dr. Battaglia, for all you do to keep the athletes in one piece. And hopefully you'll stay on the sidelines this fall when the SU football team is back in the Dome.
Spot on.
All right.
Thank you.
And thank you for being here, for taking the time to invest in your health. Informed patients make stronger decisions, and that starts with information you can trust from the people who actually provide health care in our community. That's why we do this. I'm Carrie Lazarus. We'll see you next time on Take Me to Krause.
For more information on what you're hearing on this podcast, go to krause.org/Carrie. The information in this podcast is not intended as medical advice. It's always best to check with your doctor.